Hello, everybody. I am pleased to meet you in this session on Zoom cloud meeting. I hope you are okay and I hope you are wealthy and healthy and your family almost always in the safe side. Today we discuss together the important subject, what we called um, heart failure. So we discuss heart failure case-based scenario. And let me start why I choose this subject. Because heart failure is a common problem and is worldwide common. And the most common cause of hospitalization, and it is a major cause of high mortality and morbidity. For that, I chose this title. Let me start with this advice to measure temperature of all to be away from COVID-19. And let me start with the main objective of this presentation, the background, a clinical case scenario, and the home message. I will discuss in a brief the background of heart failure. As you know, heart failure is a functional or structural problem that might lead to systolic failure or diastolic failure. What I mean by systolic failure? I mean by systolic failure, there is a failure of contraction of the ventricle. And what I mean by diastolic failure, there is impaired in relaxation of ventricle. So the heart failure, either systolic or diastolic failure, might be both of them simultaneously can occur, lead to what's called congestive heart failure. So the prognosis can be improved if we go to the early diagnosis and a proper and optimal treatment. To cover this subject, I will choose those case scenario, and I will start with this case scenario. 73 female presented with shortness of breath while lying down. She has found that using couple of pillow at night make it easier to breathe. She is hypertensive, diagnosed since 3 years, and being treated with atenolol. On examination, patient presented on examination, they found there is a bilateral basal crepitation in addition to displace of the apex speed. The first question, are you suspect is a case of heart failure? Definitely is a case of heart failure, but we put a differential diagnosis if this a case presented as a first time. And the first time presentation of such history put in your mind might be another differential diagnosis like myocarditis and other. But what that go with heart failure? There is a risk factor, hypertensive patient, and there is orthopnea. So what test would you order in this case? The answer for this question, beta nitric peptide is a marker that will be increased in heart failure, and it is beneficial in diagnosis and in prognosis. As you know, PMB level, if elevated more than 200, that indicated that the case presented with heart failure and give a clue to go ahead to diagnose more and to treat the patient. BNP beta nitric peptide in this patient around 350 picogram per ml. What the next step in such case? Also, we can add another investigation and include lipid profile, and other cardiac marker like troponin, in addition to the ECG cardiography, and sometimes patient can be do another investigation like complete blood picture and thyroid function test. So you prefer to do this patient for echocardiography. As you know, cardiography and echocardiography is an important tool for diagnosis of the heart failure to give a hint for the dilatation of the ventricle and ejection fraction, what that means, the left ventricular function and ejection fraction give a marker for function of ventricle. So the echocardiogram of this patient shows dilated and moderate impairment of left ventricle contraction with mild mitral regurgitation. So at that time, the specialist advised to add IC inhibitor, angiotensin converting enzyme inhibitor, and beta blocker. So the question, what medication would you start first and how manage the introduction of this medication? So we choose to start with IC inhibitor like carbotin and beta blocker rather than our patient already on atenolol for treatment of hypertension. But as you know, atenolol not is the best choice for heart failure. So should start first of all with AC inhibitor, and the AC inhibitor such as Rampril, small dose 1.25 milligram twice daily, and should change the atenolol to other beta blocker. Those beta blocker can be used for heart failure, and the recommendation by guideline, American and European guideline, recommend to give metoprolol or bisoprolol, I mean metoprolol or Concor bisoprolol, in addition to carvedilol as a best group of cardioselective drugs used in heart failure. So for that reason, they chose to carvedilol and to change atenolol to carvedilol, small dose 3.125 milligram twice daily. So first, the message of this management to start with small dose ACE inhibitor, because ACE inhibitor can induce hypotension as a part of the side effect. Then you up-titrate both drugs, Rampril, I mean ACE inhibitor, and carvedilol, I mean beta blocker, to maximum tolerated dose, and should monitor the renal function at initiation of Rampril and after each dose of an increment, because Rampril, it is an ACE inhibitor and one of the ACE inhibitor and might be affected in the renal function, and the one of the most common side effect of Rampril is hyperkalemia. Another case, a 71 years old male presented with breathlessness, shortness, and fatigability, and he has type 1 diabetes and angina. On examination, you found an irregular pulse. That means patient presented with atrial fibrillation and low pulse volume. As you know, the pulse, we found in this case is an irregularity, and summary of this case, 71 years old, dyspneic, diabetic, angina, in addition to irregular atrial fibrillation. So atrial fibrillation and diabetic and patient age 70. The question, are you suspect it's a case of heart failure? Definitely, you suspect it's a case of heart failure because risk factor present, ischemic heart disease, diabetes, and the presentation in addition to atrial fibrillation might be it is a cause or might be it is a result of dilatation of left atrium and left ventricle as a part of heart failure. What test would you order in this case? The answer also serum nitric peptide is the choice for determine whether case are diagnosed as heart failure. So the BMP level at this case around 500 picogram per ml. Don't forget to send all investigation like cardiac marker troponin in addition to BMP. And also don't forget to send lipid profile, don't forget to send thyroid function, complete blood picture, because all this investigation is important in addition to renal function and liver function. As you know, what next BMP in addition to BMP, the answer of this question to send the patient for echocardiography. As you know, echocardiography is important in this situation to determine whether our patient suffer from systolic or diastolic heart failure, depend on the ejection fraction. Another case scenario, a 68 years old male has exertional dyspnea, ankle swelling, and cough, and she has diabetic mellitus, diabetes type 2, and on examination, patient found hypertensive, ankle edema, and hepatomegaly. So in conclusion, this case presented diabetic, hypertensive, and hepatomegaly with ankle edema and exertional dyspnea. But on your mind, the diagnosis might be heart failure. What test would you order? Yes, definitely BMP, serum nitric peptide, in addition to other investigation. And the level in such case around 350 picogram per ml. What the test? Next step to echocardiography, and the echocardiography shows no evidence of left ventricular systolic dysfunction, but a specialist suggests that the patient has heart failure with the preserved ejection. So the question here, might we face cases with sign symptom of heart failure and they found the echocardiography will be normal ejection fraction. That was called diastolic heart failure. So the diastolic heart failure, patient presented with all signs symptoms of the heart failure, in spite the ejection fraction and chamber was normal. While systolic heart failure might presented with all signs symptoms of the heart failure, but the difference, the chambers of heart will be dilated and the ejection fraction of the left ventricle will be impaired. So this is a case of diastolic heart failure, what we call heart failure with a preserved ejection fraction. So the specialist advise diuretic in such cases. So the question, which diuretic would you start for this patient? The answer, to start with furosemide for 40 mg daily to relieve the congestion symptom and the fluid accumulation and the congestion of the liver. So the specialist also advised to introduce AC inhibitor for management of hypertension, particularly in patients with diabetes, because the AC inhibitor role in hypertension to reduce the blood pressure, and in diabetic to reduce the progression of renal damage and to prevent renal failure at the end stage. The question, which AC inhibitor would be chosen in such cases, and how would you manage the introduction of this medication? The answer, we would start with the patient with Rampri, as you know, small dose, 1.25, twice daily, and up titrate to maximum tolerated dose. The line of with recommendation of 1.2 until 2.4 milligram of NICE guideline. It is a European guideline. You should monitor renal function at initiation and up titration of Rampril, as I mentioned previously. So such case should start in diastolic heart failure, what we call heart failure with the preserved ejection fraction, should start with IC inhibitor to control the hypertension and to control the diabetes renal impairment, in addition to prevent remodeling of the heart failure, prevent convert of diastolic heart failure to the systolic heart failure, and in addition, I suggest diuretic to improve the congestion of the lung and reduce the congestion of the liver and reduce the ankle edema. Another case, 80 years old female has fatigue and weight loss, although she feels like her stomach is always bloated. Past medical history, she has history of chronic bronchitis. And on examination, you find JVB elevated and pansystolic murmur. In addition, might be this pansystolic murmur if it is in the lower external edge, suggests tricuspid regurg, and third harsh sound. As you know, third harsh sound means alveolus dysfunction. So in summary, old age female, fatigue, weight loss. In addition, she has a history of a chronic bronchitis and JVB elevated with a tricuspid regurg, and in addition to acetary. In such case, you suspect a heart failure. But the question, which type of heart failure? This is a right side heart failure. Why right side heart failure? Because the right side heart failure mostly associated with JVB elevated, with leg edema, with hepatic congestion, and the left side heart failure associated with pulmonary manifestation like orthopnea, dyspnea, paroxysmal nocturnal dyspnea, pulmonary edema, and rather than fluid accumulation which might be happening in the right side. So what test order in this case? Also, we suggest to do all investigation, but at the top of the list, we need serum nitroureteric peptide. And the result was 750. The next step, sure, echocardiography is important in such case to differentiate whether it is systolic or diastolic, and whether to differentiate it is predominantly right side or left side failure or congestive heart failure. Another presentation, another case scenario, 62 years old male, presented with dyspnea and orthopnea. He has history of COPD, and on examination, you found bilateral basal crepitation and tachycardia. Also the question, you suspect exacerbated COPD or possible heart failure. Yes, definitely we have two differential diagnoses here. Might be this a case of COPD with exacerbation, or might be new presentation of right side heart failure due to COPD, what we call cor pulmonale. What test would you order in such case? Also, we suggest to do serum nitroureteric peptide, PMP, and the level of PMP was 150. What next step? Next step to do echocardiography, and the specialists find no evidence of heart failure and suggest that raised BMP are due to COPD. As I mentioned previously, BMP in the range of 100 to 200 suggested other diagnosis other than heart failure. When the BMP raised above 200, we consider as a case of heart failure. In addition, we consider heart failure in addition to other investigation like echocardiography and other markers. Other case scenario, 65 years old female, African Caribbean ethnicity, has 3 weeks, history of exertional dyspnea, and she has past medical history of hypertension and obesity, examination bilateral basal crepitation and displace of the apex speed. This is a case definitely with risk factor of hypertension, obesity, and with exertional dyspnea and basal crepitation with apex speed. Put on your mind the case might be heart failure. What test would you order? Sure, PMB is important. The result 900 picogram per ml. Next step, sure, echocardiography. In addition to the ECG, lipid profile, thyroid function test, complete blood picture, and other renal function and liver function. Echo findings show severe impairment of left ventricular contraction, that means low ejection fraction, normal ejection fraction around 50 to 55. When the ejection fraction below 50, that means impaired or low ejection fraction, heart failure, and above 55 was normal. So the differentiation between whether systolic or diastolic depend on this number. So the echocardiogram shows severe impaired left ventricular contraction with mild left ventricular hypertrophy. The specialist advised to start with ACE inhibitor and beta blocker. And as I mentioned, ACE inhibitor is important in such case for diabetes and hypertension control, and beta blocker is important for cut the sympathetic overdrive in such cases. The answer, start with ACE inhibitor, small dose, Rampril, twice daily, and beta blocker, either carvedilol or bisoprolol or metoprolol, and will be to up titrate of those two drugs to maximize tolerated dose. And also should monitoring renal function when start of Rampril and during follow-up. If the patient develops symptoms like dyspnea or topnia, should be add another drugs like diuretic, furosemide, and should start aldactone, angiotensin, aldosterone antagonism. So aldosterone antagonism, what we call aldactone. So in addition to ACE inhibitor, beta blocker, diuretic, whether loop diuretic furosemide, or in addition to the aldosterone antagonism, aldactone, those drugs is mandatory for heart failure, in addition to the antiplatelet like Plavix and aspirin if patient suffer from ischemic heart disease. Also should add lipid lowering agent, statin group, to reduce the progression of atherosclerosis and reduce the risk of development of more complication in such cases. The patient come back 6 months later with increased dyspnea despite maximum tolerated dose of ACE inhibitor and beta blocker. What the next? The next, specialist adding second line treatment. And why we choose a combination of hydralazine and nitrate in patient with such case? I advise not to give those combination just in one case when there is patient cannot tolerate it ACE inhibitor due to side effect of ACE inhibitor, like due to angioedema or due to hyperkalemia or due to other causes that prevent to use ACE inhibitor. So the drugs that we can replace and replace the ACE inhibitor. It is hydralazine in addition to nitrate. And this combination used in selected cases when there is a contraindication to the ACE inhibitor. The patient returned again after further 4 months complaining of feeling breathlessness all of the time, particularly when she lying down to go to sleep. She has noticed her ankle to be swollen. You suspect worsening heart failure despite the patient receive optimal medication. What would you do next? The answer in this question, as you know, in case with heart failure and not response should be optimized, should be given medication as I mentioned. ACE inhibitor, beta blocker, diuretic with a loop and aldosterone antagonism, antiplatelet, the patient suffering from ischemic heart disease. Also, we can add lipid-lowering agent. And patient almost always in the heart failure should an optimized dose. That means the patient with beta blocker like bisoprolol should reach the optimal dose 10 milligram. At that time, you take at that time you say this is drug not beneficial, or that's drug. So this case cause us refractory heart failure. So, in summary, heart failure should early diagnosed and optimized in management. At that time, in such cases, you refer the patient to multidisciplinary heart failure team. Why? Because in such case, we need another advice from the interventional cardiologist, from cardiosurgeon, and from echocardiographer. Collectively, we can add another knowledge to manage this patient. The patient is seen by a member of heart failure multidisciplinary team. Her electrocardiogram, ECG, does not show widening of QRS, and therefore she was deemed not suitable for cardiac resynchronization therapy. What does that mean? If our patient with heart failure, in spite of all medication and all optimal dose of medication, there is no response, we should put in our mind another plan. One of those plans is to do cardiac transplant, which is a big and major and expensive procedure. Another plan to do what we called biventricular pacemaker. What I mean by biventricular pacemaker, I mean we put 3 leads in the heart, one of them in the left ventricle, and another one in the right ventricle, and another one in the right atrium. What that do it? That what we cause simultaneous contraction of the ventricle to retain back the heart to its work. This device implantation is a little bit big operation under local anesthesia in the infraclavicular region of the left side of the pectoralis muscle. And this procedure, as I mentioned, not suitable for all patients. Who those suitable for this procedure? Those with heart failure, NIHA class 2 to 4, that means symptomatic, and ECG shows wide QRS and left bundle branch block, and those with sinus rhythm, that means not atrial fibrillation, and should have ejection fraction around 35. Those the criteria to implant this type of device. However, if there is no this medication, should give another dose or loading dose of diuretic In addition to diuretic can add digoxin, and the role of digoxin in such cases to reduce the hospitalization. But preferable to add digoxin in patient with heart failure and atrial fibrillation, not used in a patient with heart failure alone. Another representation, a 57 years old male is a non-smoker, has a 3-week history of a dry persistent cough. The cough is interfering with his ability to sleep at night and the function during the day. He has not had any recent chest infection to account for the cough. He has heart failure, diagnosed as heart failure due to left ventricular systolic dysfunction, what we call heart failure with reduced ejection fraction, which been almost treated this case with bisoprolol, Concord 10 mg maximum dose, and Rambril 7.5 mg, what we call the ACE inhibitor. So patient heart failure presented with a dry cough. On examination, chest was clear and no sign of fluid overload. So what is the problem? What would do next? The answer has an existing diagnosis of heart failure, so you review the diagnosis. In review of such case, put in your mind 2 differential diagnoses, either chest infection or side effect of a drug. Chest X-ray shows a clear lung and renal function was normal. So there is no past history of myocardial infarction to conclude this patient might be presented with myocardial infarction or pulmonary edema or other explanation. So you should measure serum nitric peptide and beta nitric peptide level around 86. What does indicate? That indicate the patient almost diagnosed as heart failure, but now there is not in exacerbation state. That the message that BMB can give a clue for first diagnosis of heart failure and for those with exacerbation might be raised. So the cough, it is not caused by uncontrolled heart failure, not due to chest infection, not due to any problem. What would you do next to help ease the cough? The advice to stop taking ACE inhibitor and start another drug like angiotensin II receptor antagonist, ARBs, which is recommended for heart failure, like candesartan 2 mg daily, and should monitor for renal impairment and for hyperkalemia in such cases. So the patient come back 6 months later with increased breathlessness, despite being on maximum tolerated dose of ARBs group and beta blocker. What would you do next? The answer you seek a specialist advice. The specialized consider adding second-line treatment. The second-line treatment, as I mentioned, aldosterone antagonism, spironolactone 25 mg daily, is a likely drug of choice. A second line, in addition to it is a diuretic, it is antifibrotic, reduce remodeling and cut the pathway of reactivation of aldosterone. It is particularly appropriate since the patient already on ARBs group and is not of African or Caribbean origin. You monitor for hyperkalemia and deterioration of renal function. Why? Because both drugs, I mean ARBs group and spironolactone, both of them can cause hyperkalemia. So should take care when add those groups together. Other representation, a 64 years old female has 2-day history of dyspnea, a past medical history, hypertensive, and myocardial infarction STEMI, ST elevation myocardial infarction 8 days ago. which was treated with primary percutaneous coronary intervention, stenting. She is taking aspirin, 75 milligram, clopidogrel, 75 milligram, atenolol, 25 milligram daily, and rampril, 3.7 milligram daily. We found fine crepitation in the lower third of lung on examination, elevated JVB, and SO3, and renal function was normal. So the next step, we suspect heart failure after myocardial infarction. What to do? Should start with diuretic, furosemide, for relief congestion and fluid retention, and refer the patient for a special assessment of echocardiography. An echocardiography in such case found moderate to left ventricular, moderate severe left ventricular systolic dysfunction, that means heart failure with reduced ejection fraction. And shortly after acute myocardial infarction, that's what happened in the echo after myocardial infarction. The specialist advised to introduce aldosterone antagonism, I mean aldactone, following myocardial infarction. What aldosterone antagonism would you select and how you manage to reduce this medication? As in this is the case, almost always a case of the heart failure after myocardial infarction. And should put in your mind a patient with myocardial infarction, there is a risk to develop hyperkalemia and electrolyte disturbance and develop arrhythmia. To avoid this risk, should start another aldosterone antagonism, what we call eplerenone, 25 milligram daily, and monitor for hyperkalemia and deterioration, which is less side effect. In addition, less gynecomastia. As you know, the aldactone, one of the most common cause can use gynecomastia, hyperkalemia, and renal impairment. Eplerenone less in compared to the aldactone. Almost always those patients with ischemic heart disease and heart failure should start with all medication as mentioned previously. Would you change and reduce any medication? The answer, yes, should stop atenolol. There is no role of atenolol as I mentioned. Should start drugs that been licensed for heart failure, such as bisoprolol or metoprolol. Should start uptitrate ACE inhibitor and beta blocker, and close monitoring for renal function, and especially concomitant of loop diuretic and aldosterone antagonism. In such cases, one of them can balance the effect of another one. Finally, the home message: heart failure is a common syndrome, high mortality, high morbidity, and the choice of suitable drugs should be with optimization. BMB is an important marker for heart failure in diagnosis and for exacerbation, and echo is essential part for diagnosis and for management and for follow up the patient. And finally, thank you for listening to this session, and I hope to see you soon in the class. Thank you very much.